radio frequency ablation, the present and the future. Okay, so we are with you, Professor Giovannini.
Okay. Thank you very much again for the invitation, and to give me also the opportunity to speak about this very interesting new technique of ablation. First of all, I will start by the definition of the radio frequency ablation. The radio frequency ablation is the use of electrodes to generate heat and destroy the abnormal tissue. This heat is generated by a high frequency alternative sinusoidal current between 400 and 500 kilohertz, which is different than the microwave. The heat will induce a coagulative necrosis of the tissue adjacent to the probe, and the diameter of necrosis obtained for pancreatic RFA is between 1 to 2 centimeters. And we have today two types of generator, mono and bipolar. But the mechanism of radiofrequency ablation is not only to destroy the tumor by the heat injury, but also by this injury of the tumor will induce an immunomodulation as a vaccination against the cancer, against the tumor, by the secretion of cytokine and killer lymphocyte, which will have a delay effect, a delay antitumoral effect on the tumor. And this part is also very important. This mechanism explains sometimes the delay response to the radiofrequency ablation. What about the equipment today? We have three types of equipment. The RB equipment is now not available, is still in evaluation, and we have two types of probe. The AB probe, which is a very small uncoated electrode, which pass into a 22 gauge needle. But the area of destruction is very small, and we need to have a multiple puncture to obtain the destruction of 1 or 2 centimeter tissue. All the paper published today in the literature about the radiofrequency ablation use the StarMed, the Taiwan generator with this pump. This pump is very important because the needle should be cool during the procedure to avoid the carbonization of the tissue around the needle. And we have three types of needle, 5 millimeter, 1 centimeter, and 1 centimeter and a half of active part. We use mainly the 1 centimeter needle with active part. And the length of the needle completely deployed is 8 centimeters. Here you see the first animal model, and the animal model show that it was possible to destroy a large area of tissue in the pancreas. And this is one of the first ablation I did on animals. And you see the needle. Here you see the area destroyed by the radiofrequency ablation with this part, which is the carbonization, and this part should be avoided. And here you see the typical aspect with this bubble we diffuse here into the normal pancreas. And here you see the ablated area with this coagulative necrosis. In comparison, this is the RFA needle entrance in comparison with the normal tissue. And you see we have around 1 centimeter of destruction of the tissue. The first human case was presented and published now quite 9 years ago. It was the paper from Paolo Arcidiacono. And this paper showed that it was feasible, that the feasibility was around 70 to 100%, and there is no severe adverse event. And this is very important because one of the main question was the risk to induce an acute pancreatitis after radiofrequency ablation. But the first paper showed that this technique is quite safe. This was the first paper published in the literature, and you see this paper show that the efficacy in the insulinoma was 100%, and probably this is one of the best indication today is the treatment of the small neuroendocrine tumor, including, of course, the insulinoma. The results of radiofrequency ablation in adenocarcinoma, you see, it's the results are poor because the percentage of ablation is not complete as the neuroendocrine tumor, and this is because the adenocarcinoma is less vascularized than a neuroendocrine tumor, and there is a very bad diffusion of the radiofrequency current inside the lesion. Just some case, and this is a case of a patient with a small adenocarcinoma, but in fact it was an IPMN. This is a mural nodule of an IPMN. You see this lesion was enhanced after injection of Sonoview, and the biopsy show adenocarcinoma cells. And this is the ablation of this lesion, and the ablation was complete in one session, and you see the tip of the needle here, and we remove slowly. I remove slowly the needle, and to have a complete destruction. You see this bubble inside. This is a good sign, and you will see that the lesion will disappear completely. And this is the real time. Here you see that now the lesion has completely disappeared. And this is the evaluation, and this is the evaluation after injection of Sonoview. You see there is no enhancement of the area, and it was a black hole. And also on the CT, you see there is a complete non-enhanced lesion. And this patient was treated in 2016. Till last year in March, 4 years after, the patient was very well with no relapse, and she developed unfortunately in May 2020 liver metastasis due to his pancreatic cancer, with no relapse in the area of the radiofrequency ablation 4 years after. This is probably the best indication today is the neuroendocrine tumor of less than 2 centimeter, grade 1, which is, this is very important. And you will see the technique is the same with the insertion of the needle. Here you see the tip of the needle, and you will see the ablation. In very few seconds, the lesion is completely ablated. It's very important to remove slowly the needle to have a good diffusion of the current inside the lesion. This is the evaluation. 1 month after, you have a nice hypo dense area with no enhancement. And this is very funny for the neuroendocrine tumor. And I see now this I saw this completely restitution integrum of the pancreatic parenchyma in around 80% of the patient, which is very, very, very important. And the lesion has completely disappeared after just one session. And today, I can say that the radiofrequency ablation for the small neuroendocrine tumor grade 1 can replace the surgery. Another indication is the pancreatic metastasis from renal cancer. I'm sorry, this doesn't work. And you have seen the first the lesion, and this lesion was treated, but in the difference with the neuroendocrine tumor is that this lesion need to be ablated 3 times to achieve this kind of complete response, and this is after 3 months, and this is now 1 year after, and you see no, it's 2 years after, huh? Because it was 2017 and 19, and with a complete response with just this this small area as a scar. This is the first paper published in the literature of it was a multi-center study, the French multi-center study, published by my friend Marc. We have also included a lot of patients in this study, and you see that today we have 3 years of follow-up, and the results are the same. We have a very low rate of complication, 3%. And for neuroendocrine tumor of less than 2 centimeters, we have 85% of a complete response. And for IPMN, which is another indication, and we will see after, the complete response is 80%. This is the literature about neuroendocrine tumor, and this is another large study from Israel. On 27 lesions, including 7 encelinoma, and you see also a very good response, 96% of complete response. Regarding pancreatic metastasis, and this paper will be presented during the EHGC days in March. You see that the complete response is a little bit lower than for neuroendocrine tumor, and we have treated the 17 lesion, and you see that we have a 65% of complete response with 2 complications, 1 pancreatic abscess and 1 liver abscess, and this was a patient with a biliary metallic biliary stent, which probably has induced this hepatic abscess by diffusion of the necrotic cells inside the liver. But again, you see the aspect, the typical aspect of the metastasis of renal cancer with a complete destruction here with this hypoechoic, hypodense lesion in the CT scan. To conclude, EUS guided treatment with radiofrequency ablation is feasible for neuroendocrine tumor, IPMN, renal pancreatic metastasis. We have a very low rate of pancreatitis and complication. Better results are obtained for pancreatic neuroendocrine tumor than IPMN, than pancreatic metastasis. Probably there will be other indication in the future as neurolysis, plexus neurolysis. We have the 2 papers today to try to target the celiac ganglia to treat the pain, the pancreatic pain. And why not? There is also some study on submucosal tumor in which in patient in which the surgery is not possible. Of course, we need to continue to follow this patient to evaluate the duration of this response. Thank you very much for your attention, and if I hope the pandemic will disappear, I hope to see you in September in Marseille for my Congress. Thank you very much for your attention.